Hi, everyone. So welcome to the final session of this Space 2023. I'm Tony Curran, and I work at this institute on research engagement and involvement. And at this institute, we place real importance on inclusive practice. Central to all of our studies is a highly collaborative, participatory approach, which enables co-creation of evidence with NHS patients and staff and wider stakeholders. But what do we mean by inclusive practice? I like to think of it as the actions we take consciously to strive for diversity and for equity. It's also the approach we use, for example, holding the values such as respect, humility, and openness, and again, valuing diversity. So there's a lot to get amongst in a topic like inclusive research practice. What I'd like to do now is turn to our great panel that we have to discuss this subject. So I'm going to ask each of them in turn to introduce themselves and also to try to describe a characteristic or a feature that they feel is important to inclusive practice. And this may be one that's sometimes not done in the right way. So Lynn, over to you first, please.
Thanks, Tony, and it's great to be here. So I'm a patient. I live with a rare disease and multiple long-term conditions. I participate in research, I'm involved in research, and I've worked as a researcher from my positionality of my patient experience. And for me, when we consider inclusivity, we need to do it alongside considering issues such as power hierarchies and the culture in which the research has been undertaken. And by power, I don't mean this paternalistic notion of empowerment that I keep on hearing about. Power needs to be ceded, not bestowed. And for me, the question is, where does inclusivity start? Who has the power to decide what is inclusive? What methodology is used? And I ask, is inclusivity done to people, not with them? What power do the people we want to be inclusive of have over the process? Should they be included as equal partners right from the start before funding is secured? And I want to finish with the question, actually, everyone says that they want inclusive, diverse research, but actually, where does the money come to pay for it, taking account of the time that it takes to do it properly? Thank you.
Thank you, Lynn. And over to Livy, please.
Good afternoon. Thank you for having me here. I'm Olivia Joseph. I'm a research fellow for patient, staff and public involvement engagement and a current PhD student at the Yorkshire Quality and Safety Group in Yorkshire. And I think in terms of a key characteristic, it would be the researcher's responsibility for a duty of care, which is foundational to inclusive research. It's this recognition of the generational and contemporary harm and the emotional labour involved in sharing experiences, but also that sites of collective strength, resilience and innovation can exist in spaces and within people that are often marginalised. It's checking for those exploitative practices and the deficit framing, which can perpetuate harm. And I think it's really important to emphasise the importance of spaces for pause, for reflection, check-ins and also check-outs, and ensuring that there's culturally relevant and appropriate well-being resources. And I guess to end on that, I just want to say that it's really important how you extend an invitation to work together and connect, because that is an influence of how people respond and engage.
That's brilliant. So much covered already. Over to you, Ollie.
Hi everyone, I'm Ollie Williams. I'm a sociologist and a lecturer in co-designing healthcare interventions at King's College London. I was also recently funded by this institute to investigate the theory and practice of co-production within patient and public involvement. In that work, one of the things that I identified as being particularly important in this space is the need to better align what we would call technocratic and democratic rationales for doing this sort of work. So technocratic rationales would be around the reason you do it is so that you can improve healthcare, you can improve the research, and you can improve both the processes and outcomes. And the democratic rationales would be around you do this work because it makes research and healthcare fairer and more equitable. And actually, this is a marker of quality. that something is better and fairer and more equitable. So both of these are important, but what's often lost within projects is that people tend to find them to be competing. So you have different people who would place more emphasis on one more than the other, and this can often lead to conflicts and unnecessary tension. So they can be competing, but this isn't necessarily inevitable always. So I think if we did more to align these rationales and make them explicit in research programs and projects, I believe we could improve the processes and outcomes and make research more inclusive.
Yeah, I definitely agree. There's been so much to stimulate you there. Hopefully those watching are asking some questions. And finally, let's hear from Kiri.
Ngā mihi, Tony. Kia ora koutou and hello, my name is Kiri Dargaville. My background's in public health and I am the Research Engagement and Involvement Advisor at this institute. The features of inclusive practice that I think are most important that haven't been mentioned are things like diverse representation. And that relates both to your sampling method and also the composition of your research team. I think tied to that is the importance of intersectionality and understanding the cumulative impacts that social markers of difference can have on things like power, privilege, and general well-being and how that plays out. And I think one of the other features that comes to mind is a commitment to equity. And by that, I mean equity both in terms of an input and as an outcome. So having an understanding that different groups have different needs and barriers and require different approaches to achieve the same outcome is critical, I think, to inclusive practice. And equally having an understanding of the issue and how it maintains and perpetuates inequity is also important and critical to the point that Lynn made earlier around power.
Yes, indeed. Great. Okay, so we're going to try and get into some panel discussion on some of these issues now. We've said we're going to talk about practical examples of inclusive research practice and also some of the methods that can be used to support the inclusion of seldom heard people. So I'd like to push that prompt back over to the panel straight away to maybe give us one of their examples or some of the methods they might have used in this area so far in their experience. Who'd like to start us? Kiri,
I
do you
can
want
go
to?
first, Tony. I think Indigenous research methods such as kaupapa Māori methodologies have a lot to offer. Inclusivity is inherent to Indigenous approaches, and so naturally it offers principles that align with much of what was spoken about in terms of features like relationships, power sharing, self-determination, dignity, respect, so forth, so forth. And I think that the first kind of practical example that comes to mind that I think is useful in this space is the works of Linda Tuhiwai-Smith and Fiona Cram and their work on the principles of a kaupapa Māori ethical framework. And it's one example that offers guidance on what good practice looks like, both in terms of the research process itself and also evaluation. And while kaupapa Māori research is very much by Māori, with Māori, for Māori, the principles, while they're culturally centred, I think are still very much applicable to most contexts.
Yes, Lynn.
Yeah, I mean, so I'm not a trained researcher, so methodology, I kind of think, oh, okay, so who came up with that methodology and was a methodology co-produced? But I have done quite a bit of co-production, and the thing I want to talk about is co-producing a project called COVID Shielding Voices, which was a qualitative research into people's experiences of shielding. And I kind of came up with the idea and got together with Joyce Fox, another patient, and Charlotte Sharp, who's an academic rheumatologist, and we co-produced this project together. And if I relate it back, and we won an award for inclusive research, and I think I had, for the first time, I actually had the power, because we were co-producing this and we were working as equals, to try and change some of the things that I had found really jarring as a participant in research. So giving people the choice, so this was done in COVID. How do you want to participate? Do you want an individual interview? Do you want to join a focus group? Or we also invited people to submit creative materials. We offered a voucher just as a small thank for people's time, recognising that they had given up their time. We kept in touch with them all through the project. We had a celebration event where we shared the initial analysis and said to them, did this make sense to you? Did you understand what you told us? I've kept in touch with the people that participated. We recently published a policy report and we shared that with them. So there's just all those things that we did to try and make our research more inclusive. We also had the patient advisory group, which is made up of people that shielded as well, and they helped co-produce the analysis with us. And like I say, it was the first time that I really felt that I had the power to change some of the things that we're doing to try and make it, our research, more inclusive and more grounded in the experiences that people were telling us about.
And that's some great perspective. Olivia, if I turn to you, and I'm also going to kind of throw a question that we've had in from the audience here, because it relates to your opening comments and perhaps your example. So Nadine Al-Jandali asks, generational harm and emotional labour, how can we incorporate voices while applying necessary safeguarding measures to protect people who are doing this contribution?
I think it's really essential and important to for a researcher to understand and learn and listen to communities that have listen to what their kind of previous experiences have been with healthcare services, and to learn, because there's previous research that has been done, and there's history that can be read before engaging with communities that are marginalised, but also to recognise that you don't know all things, and that that you're not kind of, that language is really important, and the way that you engage with people is important. So providing space of listening, of true active listening, and to ensure that you are aware of culturally appropriate services that you can signpost to, and to, if you have enough budget and you're thinking about the finances before you engage with the project, that you build in a budget that supports well-being, that you are able to understand what spaces that they might need, so therapeutic spaces or therapeutic counsellors that you might want to bring into the room. So I think a wellbeing budget would be really useful in when you're engaging with communities that have been subjected to generational harm.
Yeah, that's great. And
also, sorry.
Yes, no, go ahead, please. Sorry,
I forgot that I was going to just also talk about a project that we conducted within the Yorkshire Quality and Safety team, which was led by Professor Jane O'Hara, and it was a responsive project within COVID-19 that wanted to understand how people were keeping themselves safe during the COVID-19 and others, and how they were engaged with healthcare services. And because we recognise that some underserved communities, like asylum seekers and refugees, that have been subjected to harm, we recognise that the extent of our knowledge going into that project, and so we thought a community research model approach might be more useful, because it might enable us to understand and go into the community with a mindset that is more of strength-based mindset, where we know that the communities have the knowledge, they have the expertise, they have the understanding. So we commissioned a qualitative interviewer to come in and to teach community service users, but also members of the community organisations, forum community organisations, to be able to do qualitative interviewing. So it was a community interviewing approach or researcher approach, which skill built, and was reciprocal learning that was engaged. And so they engaged with the communities, and they had an experienced researcher that was linked to them to enable them to go into the communities, but also that they were able to debrief and have spaces of care. And those community researchers learned a skill, but they were also involved in the sense checking and interpretation, and in the reporting as well.
That's a great example and some nice detail. There's lots more questions coming in from the audience, but just before we get into those specifics, I just want to offer Ollie the chance to come back to my more general question of his examples or perhaps methods he's used in the past.
Yeah, it's interesting. Quite a few of us have mentioned COVID, and I think that's probably not a coincidence. I think there was more money offered and more time offered during the pandemic, because people didn't really know how to respond, and there was this big space, and that void needed to be filled, and so people were more willing to open up to more inclusive approaches and sort of recognise that the inequalities that were being exposed by the pandemic needed to be addressed in this way. So a bunch of us during the pandemic were actually commissioned to put together a collection on essentially COVID-19 and co-production in health and social care, and to look at how can we be more inclusive and how does that benefit people. And we wrote two volumes. So we wrote volume 1, which was around kind of the theory behind why this is potentially useful for people to do, and then volume 2 was the practice of it. So it's just full of examples of what people were doing, not just in the pandemic, and that's important. The two examples that I'd pick out today, which are quite different, aren't about the pandemic. So the book's kind of, the title of the book is misleading because there's lots of learning in there that is not related to the pandemic. And so I think different approaches to be inclusive, you need to have different approaches. As Kiri was saying earlier, different groups will need different approaches, and you'll need to go about things in different ways. And there were two projects in particular in the book that I think highlight this. So Black Thrive, a social change or a systems change initiative that seeks to address systemic racism, and there's a particular focus on mental health within the work that they do. Essentially, they bring together partnerships of individuals, local communities, statutory agencies, voluntary organisations to address structural barriers that prevent Black people from thriving. And there's a particular focus on the inequalities that negatively impact mental health. And I think what's really important there is the identification that there's a need to address these structures, to work with people to address the structures. And then there was another project which came out of a group called Ambitious About Autism, which I thought was really interesting. So they reacted to the finding by an organisation called Autistica that only 27% of UK research on autism was spent on the top 10 community priorities. And so they took that as their starting position and worked with people in that community to find out how can we do work that's around your priorities. And the thing that they found was mental health within autism is not particularly dealt very well with GPs. So they found like a lot of young people that they worked with said that when they went to the GP because they were feeling that their mental health was taking a dive, that these issues would just be related back to their autism. And so this was a problem because they weren't getting the care or treatment that they needed. And so they came up with a project called Know Your Normal. So that's your as in you personally rather than you are. So Know Your Normal, which was about recognizing that I understand where you are, your position is, like what your mental health state is, and then understand how you deviate from that. So work with your GP so that they understand where you deviate from this, and this could be considered sort of a mental health dip, or you need some more support. And during this project they worked really closely with young people, with GPs, developed training, and it's been a really successful program, which I think is real demonstrative of why inclusive practices help to actually create healthcare improvement.
That's some really nice further examples. We don't have too long left. I'm going to turn to another question from the audience, and this is from Alice. She says, the context I'm operating in is mental health care improvement, which needs to take account of this. She'd be interested to hear about any examples of inclusion, of ensuring we include and understand the experiences of people who are unwell or not fully recovered. Any panellists would like to go for that question?
I've just spoken, but because it's we've just been funded by this institute. So Helen West is a dietitian working in eating disorders, and we've just been funded specifically to address this issue of within mental health. I think there has been an appreciation that there is a need to have more inclusive practices because of sort of the historical marginalisation and the exclusion and discrimination of people who experience mental health issues. But I think it's fair to say that eating disorder care is perhaps lagging behind within that field. And so we're looking at a particular issue of the use of restraint within inpatient units. Now, this is considered a problem. People want to practice the least restrictive practices within these inpatient units, but it is very common that people are restrained. And so we've developed a project that is hoping to co-design improvements to the service with people at various stages of recovery. So people who are in inpatient units at the time, and then also people who are recovering well in the community, and to work with them and to see how they contribute to the process and how they're able to come up with different solutions for making improvements in the service. So you can find all the details of that on this institute's website. So check out Helen West's project.
That's great, thanks. As you can see, there's so many things we could talk about here and so little time to do it. So we're just scratching the surface. One more question. This one is from our director, Mary Dixon-Woods, and she says that sometimes groups feel excluded because they can't easily be identified. For example, those who are socially or economically deprived, don't have legal status as a protected characteristic, for example. How do we do better at finding people who are excluded but aren't straightforward to identify? Yeah, Lynn.
Yeah, I think that's a really good question. Can I kind of just say that I feel a bit of discomfort sometimes. There seems to be like exclusion is like operationalized in a way, and it's about finding or identifying or whatever, when actually I think we need funds and resources to go out into communities and make those links and build those relationships, because inclusive research is fundamentally built on relationships. It's built on conversations, it's built in collaboration, it's built on trust. And so we should put money and resources into building those, and then I think good things will follow from that. And it's not a case of, well, we need to find this or we need to find that. But I don't, because inclusive research often has been, I say PPI leads say to me that researchers come to them and they say, can you find me someone that exhibits X on my characteristic because I need to involve me in a grant I'm putting in 2 days. And a lot of that is because of the culture in which we operate, because we don't prioritise building relationships and we don't put the resources into it. Yeah.
That's great. And a brief answer from Livy. Yeah, go.
So I was just can I come in and just echo what Lynn says? I completely agree that it's always responsive and not about building, sustaining and lasting relationships and dynamics where it's reciprocally and mutually beneficial for both the researchers and the communities that they're going into, the heterogeneous communities that they're going into. And I think that there is something about the terminology around seldom heard, that it's often seldom listened to and seldom asked, because those resources already exist in communities, because there is collective resilience and strength, as I said, and assets and actions that are happening within communities that already exist.
Yeah, that's great. And we always knew that with the short time we have here, we weren't going to be able to get into the detail of this, but much of what has been discussed so far is about bringing people to the fore of research, but to do that in a way that brings equity. And we need to find ways to ensure those that are seldom heard are listened to. So with just a few minutes left, what I'd like to do now is invite each of our panelists in turn to speak one last time. And I'm going to actually throw 2 questions at them, because we are conscious that there's been one question that's been asked that's been highly voted. So I was going to ask the panel for their top recommendations for improving inclusion. And what I'd like to do in addition, if they can, is think about if you had the power to implement something to introduce true inclusion and inclusive design, what would you do? So who would like to go first? Perhaps Ollie is ready?
Sure, I can talk to this. So I think it's kind of a bit of a two-parter, which is that we need to create a culture where it's normalized to that research is inclusive and therefore it's expected. So that culture would help to redefine what good and bad quality healthcare research was. So this is happening, but currently the culture change has not led to sufficient structures and ways of working to really support this work. Currently, many of the structures within healthcare research actually serve to make it extremely difficult and sometimes impossible to make healthcare research inclusive. So, for example, similar to what lots of us have talked about today, there's a lack of seed funding to make it possible for people to do the work in communities and to establish relationships with communities before you ever get to a point where a big grant is being applied for, a big program of work's being set out. And there's also inadequate or in some cases non-existent processes for paying collaborators who aren't research or healthcare professionals. And this makes it really difficult to genuinely collaborate with communities and patient or public contributors right from the very start to design research programs and projects, and then to have that be informed by their priorities. And I say that's important as well, not just to think of this on a project level, but also to think about research programs involving people in those discussions. So it's not just research institutions that are setting those priorities.
Indeed. Yeah, thanks. And over to Kiri.
That's a great question. I would like to see more emphasis placed on prioritising the research agenda of those people that we were just talking about. So those that are seldom heard. What is the issues that matter to them most? Because I think in many cases, while we lead out with the best of intentions on our respective journeys, whether you're a researcher, health practitioner, or a policymaker, I think one of the pitfalls in this space is really about whether or not you're actually focusing on the right issue, or whether you're focusing on the symptoms of the issue as opposed to the actual root cause of the issue. And so it goes back to the question that I think Lynn prompted very early on, which is who gets to decide what's an issue and who gets to make decisions about that. And so I would like to see research agendas which prioritise the voices of those groups, with the priorities of those groups. And I think one of the other things that I would like to see is being really intentional and deliberate in the points in our research where there are opportunities for shared decision-making or decision-making that's seeded. I think those are probably two things that I think are simple in practice, but probably a little bit more complicated to implement, but that's probably what I would go with.
Valuable thoughts, thank you. And over to Livy.
Oh, they both talked about the ones that I would definitely put in place, which is around funding and who's disproportionately impacted. But I would just want to say that I'd make sure that researchers have a space for reflection and understanding of their positionality and the understanding of the impact that they can do, so recognising that inclusion is everyone's business and it's everybody's responsibility, and that having roles that are associated or just for EDI professionals or PPI professionals and specifying those as members of the workforce that should know about how to engage in inclusive research practices is not enough, that it needs to be throughout and embedded within research systems, processes, and researchers have a responsibility to understand that.
That's great. Just before I turn to Lynn, I would like to just say to those whose questions haven't been answered, we will all be in the Meet the Speaker session that's about to start. So please do join us there. Or alternatively, if you're not able to, if you'd like to send me your email address by a private chat on the platform, we will give you a short written response to your question instead. Lynn, over to you.
Yeah, so I think that reflexivity, so that sensitivity to how our thoughts, feelings, biases, assumptions, life experiences affect how we think and feel about things is just essential to inclusive research, and that can be really uncomfortable. And what I've learned about reflexivity is once you've switched it on, it's really difficult to switch off. And I think it just really makes you look at yourself. And what I would say is, and going back to a point that Olivia made about the emotional labour, and this is not people being emotional. This is the hard work involved in being involved in sharing your experiences. And if you can't respect that, if you can't understand that, then don't do it. Don't say that you're being inclusive. Don't try to be inclusive, because you can do massive harm as a result. So understand that about yourself and realise that working inclusively is not for you.
That's some real food for thought. And I suppose what that what that relates to is that we have to think about things, don't we? We have to have humility, we have to learn. And I think asking ourselves some difficult questions before we go about this practice can help. How can we learn from others or from training, etc.? How can we then change our practice from that? And how can we think about questions like who might be excluded, who might be underheard, and whose voices might be missing from the practice we currently have? And to finally answer one person's question, will these sessions be shared afterwards? They will indeed be available on demand after the conference on our YouTube channel. And with that note, thank you very much, panelists, and I hand over back to our event host.
Thank you very much, Tony. And wow, what an incredible session. And this is something that's close to my heart. All the panelists, Ollie, Olivia, Lynn, and Kiri, I'm really grateful for sharing your voices today. For me as a patient advocate, it's really hard to find patients from different cultural groups. And I had no idea that racism is still going on. I talked to Leanne Perro, head of Black Women Rising, just to try and give women of colour a voice in the online patient cancer space. And it's really hard to be truly inclusive. So thank you for this incredible discussion.